A patient with a 2-week history of headache develops the acute onset of diplopia associated with evidence of a pontine tumor by MRI. A lot of patients, by the way, who develop tumors will develop headaches because that tumor occupies space and it elevates intracranial pressure. In other words, anything that occupies space within the cranial cavity, whether it be a tumor, an aneurysm, a bleed, okay, if it occupies space, it elevates pressure. And one of the earliest signs of increased intracranial pressure is headaches. Okay, but in addition to headaches, she also develops the acute onset of diplopia. When you hear diplopia, the first thing you think about is she must have a disconjugate gaze. There has to be a problem with 3, 4, or 6. Okay? It says the MRI demonstrates a pontine tumor, a tumor in the pons. Okay, well that helps out a lot. Okay? Why? Because of 3, 4, and 6, the only one that comes off the pons is 6. So this has to be D.
It's 1 to 4, 5 to 8, 9 to 12.
Remember the rule of 4s. So the correct answer there is D. Number 2, a 21-year-old female is undergoing an evaluation for complaints of recurrent headaches and loss of vision. An MRI reveals evidence of an aneurysm along the brainstem. In addition, formal visual field testing depicts a left homonymous hemianopsia. The aneurysm is most likely compressing. Well, the only one of these that would cause a left homonymous hemianopsia is a right optic tract lesion, C. Again, if you missed it, study your pathways. Number 3, a patient undergoing surgery to the parotid gland is at risk of damage to which of the following cranial nerves? Well, we talked about the fact that cranial nerve 7 exits the skull through the stylomastoid foramen and directly enters the parotid gland. And in fact, within the parotid gland, it branches extensively. And so the big risk, the primary risk associated with parotid gland surgery is damage to the 7th nerve. So that would be B. Number 4, damage to cranial nerve 3 would result in which of the following neurologic deficits? A, ipsilateral blindness. No, that would be a cranial nerve 2 problem. B, inability to fully close the eye. No, that's the function of 7. The correct answer is C, upper eyelid ptosis. D, inability to form tears would be a problem with 7. So again, C. Number 5, which of the following nerves provides innervation to the parotid gland? That would be B, the vasopharyngeal nerve. Okay. Next is a picture. We see a 65-year-old male presents with a history of progressive difficulty with oral manipulation of food and difficulty forming certain sounds during speech. Neurological exam demonstrates his tongue is deviated slightly to the left, and he's got atrophy along the left side of his tongue. Okay? So I'd ask what cranial nerve deficit is evident. It would be D, a hypoglossal. In light of the muscle wasting evident, this deficit is clearly due to which of the following lesions? It would be D, a lesion involving the left cranial nerve nucleus. Okay, remember that with brainstem lesions, the tongue deviates to the side of the lesion. So it would be a left whelk nerve nucleus. Number 8, if light is shined into a patient's right eye and there is no direct response but a positive consensual response, this would represent C, a right oculomotor nerve deficit. 9, we have this picture here in which the patient is asked to smile and close her eyes tightly. And you notice that she can't lift up the right corner of her mouth. So she's got some dense lower facial weakness. With regard to the upper face, she can close her eye, but not to the same extent as on the other side. So she's got a partial upper facial weakness. Well, the cranial nerve involved is the right 7. That's where the weakness is. But is it upper or lower motor neuron? It's upper. Upper. The fact that she can close her eye means that she's got some partial strength from ipsilateral upper motor neuron innervation.
Okay.
Okay? If she had a lower motor neuron deficit, then she wouldn't be able to close her eye. Okay. Now, you know, to be honest, the one thing I really like about A&P, about anatomy and physiology, is it has direct applicability to clinical situations. If you understand anatomy and physiology, then you get to a point where you can evaluate patients and you can connect the dots. You can say, okay, this patient's presenting with these signs and symptoms. Based on my knowledge of anatomy, it's got to be located here. This has to be a lesion located in this particular location. So it's not good enough just to be able to memorize.
Right.
This is what I'm saying. You have to be able to connect the dots. Otherwise, that memorization is kind of useless. Well, right now, it's mostly anatomy we're talking about.
But like connecting the dots, isn't that physiology?
Well, it can be either.
Okay.
It can be either. All right, so today we're going to talk about the autonomic nervous system. And this is important because a lot of pharmacology is based on understanding the autonomic nervous system. You know, some drugs work by interaction with receptors, okay? And those drugs either stimulate receptors that are used by the autonomic nervous system, or they block those receptors. Now you have another class of drugs that are receptorless drugs. They don't involve the autonomic nervous system. But for those that do act upon receptors, to understand how the drugs work and the potential side effects, you have to understand the autonomic nervous system. Now, if we were to talk about the somatic motor system, okay, where, let's say, a skeletal muscle is being innervated, that pathway from the spinal cord to the effector involves a single neuron. It would have its origin within the anterior gray horn. Its axon would lead via the ventral root, join a spinal nerve. It would pass through a plexus and a peripheral nerve, and ultimately synapse with the cells of the skeletal muscle. All right, so this is a somatic motor neuron. Again, a single neuron between the spinal cord and the effector. Somatic motor neurons release the neurotransmitter acetylcholine, which I'll abbreviate ACH.
Thank you.
Now, a neuron that releases acetylcholine as its neurotransmitter would be referred to as a cholinergic neuron. And in fact, to take it a step further, the receptor along the postsynaptic cell membrane, which binds acetylcholine, would be referred to as a cholinergic receptor. That's pretty straightforward. Okay, what about the autonomic nervous system? The autonomic nervous system provides innervation to smooth muscle, cardiac muscle, and glands. So let's draw an effector here for the autonomic nervous system. Let's say the heart. The heart really doesn't look like that.
Really?
We just symbolize it, yeah. It's just the way we symbolize it. Most organs innervated by the autonomic nervous system, by the way, receive innervation from both the sympathetic and the parasympathetic division. There are some organs that only receive innervation from one, but most receive innervation from both. Now, in this case, from the spinal cord to the effector, instead of being a single neuron pathway, it's going to be two. It's going to be a two-neuron pathway. And the pathway is going to originate within a lateral gray horn, perhaps of the spinal cord. If it originates within a lateral gray horn of the spinal cord, because it's a motor neuron, its axon is going to exit via the ventral root and join a spinal nerve. That axon is then going to synapse with a second neuron, whose axon will continue all the way to the effector. So if we're talking about the autonomic nervous system, the pathway that extends from the spinal cord to the effector is actually a two-neuron pathway. Now, it's never simply two neurons. We usually have this group of neurons like this that snaps with a group of second-order neurons. Okay. So the synapse is going to occur within the peripheral nervous system. And this group of nerve cell bodies within which the synapse occurs is going to be called a ganglion. Because a ganglion is a group of nerve cell bodies within the peripheral nervous system. Okay. In the case of the autonomic nervous system, the first neuron is going to be called a preganglionic. Neuron. And then the second neuron in the series would be called then, what do you think? Yeah, postganglionic neuron. Preganglionic neurons tend to be myelinated. Whereas postganglionic neurons tend to be unmyelinated. Yeah. Now, these autonomic pathways that are depicted here can either be part of the sympathetic division of the autonomic nervous system, or they can be part of the parasympathetic division of the autonomic nervous system. Another name for the sympathetic division of the autonomic nervous system is the thoracolumbar. So, sympathetic and thoracolumbar are synonymous. Now, the reason that we call the sympathetic division the thoracolumbar division is because the cell bodies of the preganglionic neurons originate either within the thoracic segments of the spinal cord or the first two lumbar segments. So within the T1 through L2 region of the spinal cord. Hence the term thoracolumbar. Okay. On the other hand, the parasympathetic division of the autonomic nervous system is also referred to as the craniosacral division. Why? Because the cell bodies of the preganglionic neurons either originate within the brainstem, in other words, at the site of cranial nerve nuclei that carry parasympathetic fibers, 3, 7, 9, and 10, or within the sacral region of the spinal cord, S2 to S4. So craniosacral, because the cell bodies are located either within the brainstem, within the 3rd, 7th, 9th, or 10th cranial nerve nucleus, or within the sacral division, S2 to S4. Now, if an organ is located within the head and neck, the thorax, or the abdomen, and it receives parasympathetic innervation, then that parasympathetic innervation is coming from 3, 7, 9, or 10. Again, if an organ is located in the head or neck, thorax, or abdomen, its parasympathetic innervation is being supplied by 3, 7, 9, or 10. On the other hand, if an organ is located in the pelvis, then its parasympathetic innervation is coming from a sacral segment of the spinal cord, S2, 3, or 4. All right. This is actually fun once you get to know it. It's that initial part.
Learning.
Struggling to understand it, that's a little bit daunting. Where's the magic stick? Here it is. Don't worry.
Yeah, I was really
I feel like
worried.
you need a tracker on that. You just like hit a button and it'll like
You
start
do.
beeping.
Yeah, that would be great if you could, like, that could be like a Christmas gift.
How about I just patent it and make millions?
You could do that.
And then give you
Magic
like